Amy Trees. I'm a respiratory therapist. I work at Mission. I have special credentials in pulmonary function testing, and I've been asked to talk with you today about spirometry. I hope you'll find it interesting. Some of the slides might seem a little blurry or confusing, but not to worry, you're going to receive handouts of everything that's covered in this session. So we're going to begin by talking about spirometry with showing you this slide, and this is just a snapshot. It's from the American Thoracic Society. It talks about standardization of spirometry. So all the information that's presented in this time is coming from this article. And it's a long, lengthy article, but basically it has three emphases. And the first emphasis is the equipment. Does the equipment that you're using for spirometry, does it work well? And if it works well, how do you know that? And so there needs to be some sort of system in your clinic area that shows that you do quality control with your equipment. And that should be done daily. Calibrations are vital to show that quality control is keeping your spirometry equipment working well. And that quality control measure just means that it's okay to use that equipment for clinical use. The second emphasis is going to focus on the patient. Can the patient do the maneuver that's needed for spirometry? Do they understand it? And are they able to do that test with good effort and good technique? And the third thing that this article is going to focus on is what to do with the information. You can't just do one blow and call it a day with spirometry. You have to repeat it, and it has to be done right. So you're going to want to do at least three good acceptable measurements, but maybe not so much more than 8. So you have to kind of know, is the information that you're getting, is it acceptable and is it repeatable? And we'll talk just a little bit more about that in a bit. So the patient, what to do with the patient? Well, the first thing you're going to want to do is to get height and weight. Height and weight's a necessity. And the second thing you're going to want to know is, have they recently been sick? Have they taken any medicines lately, especially albuterol? Albuterol is a medicine. It's a fast-acting bronchodilator that can change and make the spirometry look better than it might actually be. So you're going to want to know if that's been taken recently. You might want to know if they have a history of smoking. The second thing you're going to want to do is to explain to the patient what's coming. All patients like to be reassured of what's going to happen next. And so the best way to reassure your patient is just to explain and demonstrate. So you might just want to pull up a chair and say, for example, to Mrs. Smith, "Hi Mrs. Smith, I'm Amy. Your doctor's ordered spirometry, and I just want to let you know that it's a simple breathing test. I'm going to have you sit up nice and tall, and I'm going to ask you to take the biggest, deepest breath in that you can, and then I'm going to want you to blow out as fast and as strong and as long as you can. And when you can't blow out any longer, I'm going to ask you to breathe it all back in." And so Mrs. Smith, it's going to look like this. Big breath in. Blast out. Keep blowing, Mrs. Smith. Blow, blow. Keep blowing. Empty, empty, empty. Now breathe it back in. Good job, Mrs. Smith. And that's what it's going to look like. And that would be considered one attempt. All right? So, how do you know if Mrs. Smith did well? So an acceptable attempt or an acceptable maneuver is one that, well, let's say it this way. Let's go on to the next slide. One where Mrs. Smith didn't cough. Mrs. Smith didn't have a leak. For example, she was breathing out of her nose and her mouth. The leak would be your nose. You want all the breath to be captured through the mouth. Mrs. Smith didn't have an obstruction. For example, she didn't have her tongue in the mouthpiece, so that airflow needs to be open, coming straight through the mouthpiece. She didn't just give a quick blow and that's it. It has to be a long blow. It has to be for 6 seconds if Mrs. Smith is over 10. And if she's younger than 10, 3 seconds is acceptable. And there needs to be a plateau, and I'll show you what that looks like on a later slide. So 6-second exhalation with a plateau equals acceptable. This slide just repeats what we've just talked about, that Acceptable means a really good start with a really long, full exhalation, and then that plateau that we talked about as well. All right, so this is an example of what spirometry looks like. This is an example. On the one side, there's two separate graphs. One looks like loops, and one looks like straight lines. The loop is called the flow volume loop, and the straight line is where we're going to talk about that plateau. See how it goes like this? Well, this where it levels off is considered the plateau. So, if Mrs. Smith is blowing out, big breath in, blasting out, 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 the breath is going to ramp up, up, up. But when she plateaus, is when the line gets straight. That helps with getting an acceptable test. This is just an example of Mrs. Smith not trying very hard. She just kind of didn't give a good effort. She didn't understand that whenever you do spirometry, you have to really blast. For example, like your breath is a rocket. It really has to punch. That first second is a critical measurement, and so it has to be a strong blast. This is an example of glottic closure, meaning she just kind of stopped or started coughing at the very end. So that would not be an acceptable test. This is an example of an obstruction. And so remember, no tongue in the mouthpiece. That'll mess up the movement. One of the main things about spirometry is the effort good? Remember, to be acceptable, good strong effort with good strong exhalation. So it has to be deep breath in, forcefully blast out fast, blast out strong, and blast out long. And the way I like to remember this is by thinking of the mountains. You know, some of the mountains roll, and they're like rolling hills. Well, a rolling breath is just kind of it's really not a strong effort. But those Rocky Mountain highs, they peak, and they're pointy. And so good effort makes for pointy flow volume loops. And so when the effort is big breath in, with a blast out, it's going to peak on the flow volume loop. And that's an important thing to notice. See how each of these flow volume loops have pointy, pointy tops. That's good effort. That's acceptable. Let's talk now about inhalers. Sometimes spirometry, if it's not acceptable, if it's acceptable but the results look not as normal as the physician would like, or the physician is interested in seeing, is there room for improvement, albuterol may be ordered. And then when albuterol is given, wait 10 minutes after that treatment, and then repeat spirometry. That's called a post-test. And so, if there's improvement, you can see on this slide, there's a small pink loop, and then there's a bigger black loop. That means there was improvement after the medicine. That helps the physician treat the patient for better control. So I just wanted to talk a second about reversible obstruction, and that is when there's improvement, and you can see on the slide there's a plus 19. That's an FEV1 plus 19. That's significant improvement. There's a plus 21 on the effort. The patient tried hard both times because you can see pointy peaks on both the pink and the black. So good effort both times, and yet the patient got better after the albuterol. That's significant reversibility. That's important information. So I just wanted to show you how you capture a post. And then I think we can stop now before we go on to the second session about nebulizers and inhalers.